Thank you. Thank you very much. I'd like to add my voice to the chorus of thanks and appreciation to Esper for putting together this wonderful program and for the hospitality that he has shown the speakers who are here. Dr. Watkins is always a tough act to follow, but I can guarantee that your English is better than my Portuguese, so we'll go that route for today. I'm going to talk about the reservoir of HIV infection, and that's really an interesting concept and term, because when you say the reservoir, you can mean any one of a number of things. And what I'd like to convince you of today is the really important, the great importance of very carefully defining what you mean by the reservoir and what you're trying to accomplish when you talk about it. Because if you go through the front row here, everybody's going to have a slightly different definition of the reservoir depending on what they're studying and what they're trying to accomplish. So the first point that I'd like to make, and we can go to the example of the Mississippi baby. And this is a child that was born and infected at the time of birth and immediately put on antiretrovirals, and at some point was taken off of antiretrovirals, and the virus came back after 20 some odd months. And people were very surprised by this. And the editorial said it is unclear where in her body the virus hid during those 27 months of negative tests. And so that's the first question we need to answer, is where are the virus-infected cells predominantly, and how important is that, and what's the dynamic nature of those cells with antiretroviral therapy and without antiretroviral therapy. And we can look at that, and we can answer some of those questions. So, that's interesting. So the first point that I want to make is that we should just understand how the virus gets into the body and what its route is, what its path is to establishing that reservoir. And so you have the mucosal surface. The virus comes through that mucosal surface. I don't want to get into how that happens because I frankly don't know. I mean, I think this is still an area of active investigation. But the point is that there's an infected founder population of primarily CD4 T cells in the submucosal surface. You have, in the first days of infection, you have local expansion of those CD4 infected T cells and seeding of or dissemination to a local draining lymph node. Via the lymphatics, that can go through enter central circulation, infect other lymph nodes, gut, brain, liver, lung, etc. And this is the route by which most people become infected with HIV. But the point is that once it gets past this local mucosal surface, it's widely disseminated. But the question is, where is it disseminated to? And what's the proportion of infected cells in each of these tissues? Because if you're going to study a cure, or you're going to understand the pathogenesis, you have to know which tissues to go to look at that and understand that, because the environment is different depending on where you go. So the tools that I have to use, and what I do, is pretty much histologic. So I'm looking pretty much at tissues under the microscope. This is in situ hybridization for HIV RNA of a lymph node from a patient who has been in acute infection. So at this stage of the game, this particular patient's HIV RNA in the peripheral blood, in the plasma, was negative. I'm sorry, the plasma RNA was positive, but their antibody test was still negative, so truly acute infection. And what you see is signal that's been hybridized over cells that are expressing HIV RNA. So if you remember back to Dr. Kaup's talk, he focused in on just the parafollicular T cell zone and the B cell follicle, and that's where we are here. So this is all the T cell zone, this is the parafollicular T cell zone, and this is a B cell follicle. With this test, you can't easily distinguish the primary follicle from the germinal center, but all of these are HIV RNA positive T cells. they're in the parafollicular T cell zone, they're making virus. They're churning out virus at a fairly high rate. The B cell, or the follicle, there's a particular structure in the follicle called the follicular dendritic cell network. It's very important to antigen presentation and B cell responses. And this is what you see here are whole virions that attach to the FDC network, and they're held there via antigen complex. And of course, that's what they're supposed to do. The issue is that there is so much antigen that this system becomes overwhelmed. And so you see just orders of magnitude greater numbers of virions that are attached to this FDC network. These virions attach, they can come off, they're still infectious when they can come off, and they can go on to infect new CD4 T cells. But one of the things that I want you to take away from this is that there's just an enormous number, very big number of CD4 T cells or infected cells in the parafollicular T cell zone, and there's a lot of virus sitting on in the B cell follicle on the follicular dendritic cell network. We can also apply a slightly different technique called termine signal amplification with a different substrate, and so this is still in situ hybridization, but what you're able to visualize in this application are the individual viral particles under extremely high magnification. And so you can begin to get a sense, a quantitative sense for how much virus is produced, but also is it important if that virus is, if that cell is activated, or if it's a resting cell, and does that make a difference in terms of how much virus is produced, and what are the factors that control that? And so this is work that was done by Ashley Haas, who you've heard about earlier today, and Kevin Riley, who's our biostatistician. And what you see here is the picture I just showed you, which is you can see there's a very large cell here with this cloud of virions around it. But I don't know if you can appreciate with this, in these lighting conditions, but you can see that this cell is much smaller with a much smaller cloud of virions around it. And this cell is Ki67 positive. So by that measure, it's an activated T cell. This cell is Ki67 negative, and at least by that measure, it's in more of a resting phenotype. Now, you can make the argument that we really can't call this a resting cell because we haven't done the other markers of activation, but at least by Ki67, we can call it that. And I do want to say that one of the limits of this type of analysis, so a histologic analysis with in situ hybridization, one of the limits is that, I get 2 colors plus the in situ. Danny gets 100 and some odd colors and all kinds of stuff. But that's the difference between flow and immunohistochemistry. So what I can tell you is spatial localization. I can tell you the phenotype. I can tell you how close it is to an effector cell or something like that. But it's different information. It's contributing to the overall picture of the pathogenesis of the infection. But the point is that depending on the activation state of the cell, it's going to be making different levels or different amounts of virus. So when it's at least Ki67 positive, you have 191 virions being expressed at that snapshot in time. Because remember, this is just a lymph node that's been removed, it's been fixed, and you're looking at a snapshot. Versus this Ki67 negative cell in a more resting phenotype that's expressing in this snapshot 34 virions. So this is the type of information that we can collect histologically, and we can start to combine it with some other measures that colleagues have done on those same tissues and get a much better insight into what's happening at that stage of infection. So this technique that I showed you, the in situ hybridization, the radio-labeled, it's a radioactive probe that hybridizes over HIV-infected cells that are expressing HIV RNA. This is a technique that we've had in our lab for years. It's a fairly fussy technique. It depends on the age of the probe. It depends on a number of issues. Jake Estes more recently has applied a more modern technology, and that's the RNA and DNA scope method of detecting nucleic acids in cells. And so the main advantage of the RNA scope is that it is much more facile, it's not quite as fussy, and it can be done in a day. This technique is pretty fussy. It can take 14 to 21 days exposure. You have lots of problems with background sometimes when you're doing this assay. But the advantage is that it's a linear assay, and as I'll show you in a moment, we can more precisely quantify the number of virions that are on the FTC network than we can with this assay because it's an amplification. There's an amplification step. The other main advance here is the assay called DNA scope. So now for the second time really, we can easily detect cells that have HIV DNA in them. And it's a little bit hard to appreciate on this slide, but you can see this signal amplified over the nucleus of the cell, and these are cells that have HIV DNA in them. So DNA positive cells, and this is really the first time we've been able to do this in a very easy way. And this is just a different, more magnified image showing you DNA positive cells, and you can see that signal localized over the nucleus, and we can count that. Now the caveat to this is that there's a lot of artifacts with these particular assays, and so it takes some time to learn how to interpret them and to properly count the number of positive cells. All right, so let's take some of these techniques and try and understand what we can about the, in this case, the location of the reservoir. So this is a treatment interruption study that we completed a few years ago now. And what we did was we took HIV-infected people who had been on therapy for an average of 10 years, who were well suppressed. Their median CD4 count was in the 500 to 600 range, and their HIV RNA in peripheral blood was completely undetectable by standard commercial assays. We did a lymph node biopsy. We did colonoscopy to the terminal ileum and to the rectum to take gut-associated lymphoid tissue biopsies. And then we stopped their antiretroviral therapy. And there's a lot of nuances to this that I could talk about, but in effect, we stopped their antiretrovirals. The patients came back to the clinic every Monday, Wednesday, and Friday for a plasma viral load. And at the time that they were detectable, we brought them back, we did another lymph node biopsy, we did another colonoscopy, and then we restarted their antiretrovirals. And so before I get into what we found, I want to assure you that their CD4 count it initially went down a little bit, and then it came back to normal. Everybody's virus was completely suppressed when we restarted antiretroviral therapy. There was no emergence of resistant virus. This turned out to be an extraordinarily safe method for evaluating these kinds of questions. And if you think about it, when we get into cure therapies, when we get into interventions where we want to see if we've cured the patient, what are we going to do? There's probably only one strategy that's going to test the effectiveness of those interventions, and that's this treatment interruption. So we've shown that this is safe and can be done. All right, what have we learned? In this plot, I'm showing you the time to plasma viremia after interruption. So this is the quantity of HIV RNA in the plasma, so it's plasma viral load. And this is the time to recrudescence, so the time to detection of plasma HIV RNA. And each of these is a patient, and what you can see is that most people recrudesced after about 2 weeks. Very predictable. The median viral load was in the 600 to 700 range. I've listed them here. There was one patient who made it out to day 30 without any recrudescence of viremia. The protocol stated he had to go back on therapy we wanted him to go back on therapy at day 30. He refused to go back on therapy at day 30, so I was able to ask him to give us another set of biopsies. And he came in 3 days later for his biopsies because he had to do the prep and all that stuff. And the day of the biopsies, he was viremic. So all of these patients became viremic on average 14 days after therapy, and these are the viral loads that they had at the time that they were biopsied. And this is the in situ data. So there was, as I said, a rapid recrudescence of viremia from multiple anatomic compartments with surprisingly high amounts of virus, much more than I would have expected if you go from absolutely no virus in the tissues to 2 weeks later, you have recrudescence in the plasma, and then I'm being able to get tissues on average 2 to 3 days after that first time point where we're detecting it in the plasma. So each of these rows is one patient. This patient, for example, this is a lymph node. That's a germinal center, a B-cell follicle, and the amount of virus on that B-cell follicle and that B-cell follicle on the FDC network is what we see in chronic HIV infection. And here's the terminal ileum, and you see this cluster of viruses, or CD4, this cluster of cells that are expressing HIV RNA, and the start of accumulation on the follicle. This is rectum, ileum, and again you can see that there's these positive cells and this cluster of positive cells here. Same patient, biopsied the same within 5 minutes of each other. Here's another patient, again, lymph node and gut, and you can see the single positive cell, this cluster of positive cells. So the point from this is that we can see multi-anatomic, we can see multiple sites that are HIV RNA positive upon recrudescence of this virus. Now, this suggests that when you stop therapy, when the virus comes back, it comes back from multiple sites. So it's like it just turns on systemically and you get virus everywhere. Now you can't rule out, however, with this particular analysis, you can't rule out that we just missed it, right? It started from one site, disseminated, and got to these other tissues and began replicating. Because the question we're really trying to ask is, what's the source of recrudescent viremia? Where is it coming from? Is it one cell, so a single founder that expands rapidly, or a couple of cells that expand rapidly, or is it just, boom, you have virus everywhere? So it's really impossible to answer that kind of question with these kinds of histologic approaches. So what we did was we worked with Brandon Keel in Jeff Lifson's lab, and he did amplification from the plasma and PBMCs, and just to ask the question of how big is the founder population. So if it's a single cell, and so blue is like in this patient, blue is plasma HIV RNA, orange is PBMC viral RNA, and purple is PBMC DNA. If it's one cell that activates, or two adjacent cells that activate and start making virus, this is what you'd expect to see in the peripheral blood at the time of recrudescence. You'd expect to see one clonal population expanding. If it's multiple sites of activation from multiple cells, you would expect to see these patterns more. And that's exactly what you see in almost all but one of the patients. So I forget what the total N was, 14 patients or something. This is what we saw, and in only one patient did we see this. And you saw this, so a little bit more clonal here, but all of the rest of them, they really were from multiple sites. So from this we can conclude that when you reactivate, or when you take away antiretroviral therapy, and if the virus reactivates, under these conditions, it's coming from everywhere. It's a little bit like keeping a lid on a boiling pot. If you take that lid off, if you stop the antiretrovirals, things will just boil over and it will come back from everywhere. At least that's what this data would suggest. So what you have then, I said that your two choices were a single focus of recrudescence, so reactivation from one or a few cells. You have a small infected founder population with expansion, and then that cycle that I showed you before with draining into the thoracic duct and dissemination to the lymph nodes, the spleen, and the other organs. The other possibility is this multifocal reactivation, which is indeed what we saw when we looked at the tissues from the latent pool, or from the pool of latently infected cells. This still doesn't answer the question, and I can't answer it with these data. Was there persistent replication going on in the tissues? Because remember, we saw surprising amounts of virus on the follicular dendritic cell network. So was that there before? I can't answer that with this assay because it's a point in time. We took out one lymph node, and we don't have sequencing studies to say that this virus is evolving. but these data certainly support that idea. All right, well, how much virus is there and where is there exactly? So where are these pockets of infection? So we did recently we completed an experimental protocol to examine the location and size of tissue reservoirs. So in this particular case, we had 3 monkeys, monkey 1, monkey 2, monkey 3. We infected the monkey with SIV MAC 251, so standard stocks of SIV. We came back in one of the monkeys at peak viremia, which is approximately day 10, and we necropsied the animal. The next animal we let go for 30 days, and we necropsied the animal, and at day 75, and we necropsied the animal. From these animals, we took every tissue possible. So what we wanted to do was survey the animal from the top to the bottom, every organ we could get to understand where were the reservoirs of infection and how important were they. So some of you may or may not know that there's something of a debate in the literature about where are the important reservoirs. So you can find literature out there to say that kidneys, for example, are a very important reservoir of infection. Or the liver. I can point you to articles that talk about the lung or the brain or lymph nodes or gut or whatever. But we were really trying to understand where are these cells and how important are they? So we took these tissues and we did our routine histologic analyses and simply counted things. How many cells were there in those tissues? So I just want to show you some pictures first so you can get the idea of what we were looking at. Here's the kidney. And this is very representative of what we were finding. They were rare, they were perivascular, and they were CD4 T cells for the most part. This is the liver. You're only seeing one here, but they were a little more frequent in the liver. In the heart, rare. In the spleen, however, they were very frequent, and you saw accumulations, and it's because it's an immune tissue and has follicles, you saw accumulation on the B cell follicles. In the brain, they were a little more frequent. It's hard to appreciate with this projection. Here you have a vessel, you have a lymphocytic infiltrate, and you have this cluster of SIV infected cells in that perivascular location. So if you go through, these are the tissues that we looked at, heart, brain, et cetera, down to spleen. And we can count the number of cells per gram of tissue. And I could show you how we get to that, but it is per gram of tissue. We also know the organ weight. So how many grams on average, what was that organ, should it be? And then we can tell you the total number of cells per organ. So now we can give you some estimate of how big the reservoir of infected cells is within each organ system. And the thing that I just want to point out to you here is the lymph node is 10 to the 8th cells per gram of tissue, and the gut is 10 to the 9th cells per gram of tissue, and all of the other tissue sites are orders of magnitude less. With the possible exception of the lungs, you have significantly less in these other tissues. And when you put it all together, if you add lymph node and gut, and spleen, you're accounting for 98.4% of the infected cells in the body. So the take-home message here is that the reservoir of RNA-positive cells, so here I'm defining it very specifically, the reservoir of RNA-positive cells, most of those are in lymph nodes and gut, and if you want to learn about them and understand them, that's where you need to go. That's where you need to be looking. All right, how consistent is this across lymph nodes? So here we have the axillary, colonic, inguinal, and mesenteric nodes in these monkeys, and then you have the day 10, day 30, and day 60 animal, and this is the frequency of RNA-positive cells per gram in these lymph nodes, and you can see that it's very consistent across these sites. So at least in terms of lymph nodes, you can say that an inguinal lymph node in humans, which is easy to get to, an inguinal lymph node is representative of other lymph nodes in the body. And this data would support and suggest that. And this is important in human studies because if you're going to measure this, it's easiest to get to the inguinal lymph node, whether you excise it or do an aspiration or however you're going to measure it. You know that you're looking at something that's representative of the rest of the body. And that's an important point to make. We've also done studies, I'm not showing this here, we've also done studies in humans where we've had the opportunity, either at autopsy or because they were needed for clinical reasons, to look at axillary, cervical, and inguinal lymph nodes within a week of each other, and the same data, they're the same. We get the same amount of virus. So that's the first point. The other point is that, and the other point that I want to make is that the frequency per gram of tissue is the same in the lymph node as it is in the rectum. And I'll talk more about, and so, you know, when you're measuring this is in terms of RNA positive cells. So when you're looking in the gut and your question is that question, then looking in the gut appears to be representative of what you would find in the lymph node. All right, so that's one reservoir, RNA positive cells. And of course, we can treat those RNA positive cells with antiretrovirals, and we'll talk a little bit more about that in a moment. But there's another reservoir that is extremely important, and that's the follicular dendritic cell reservoir on B-cell follicles. So I showed you the outline of the follicle here, and you can see all of the RNA that's decorating the follicular dendritic cell network, and there's these positive cells that are churning out virus as well. In a cartoon form, this is what it would look like. So here's your germinal center, here's your follicular dendritic cells, and then you have these processes that come off of the dendritic cell. This is sort of like the skeleton of the B-cell follicle, and you can see the antigen, in this case HIV RNA, or HIV virions, that are decorating the follicle. So in the T-cell zone, you have infected cells making virus. They get brought into the germinal center and are deposited on the FDC network. And there's one circumstance that I'll describe in a moment where this actually happens in the germinal center. But this is what this looks like. You have the nucleus with these processes and the virions that are associated with it. So looking at it in another way, you have the processes, the cell bodies, the processes, the viruses that are attached. And so these viruses can come off, and they can infect CD4 T cell, or T cells that are in the follicle. In other words, T follicular helper cells. So these T follicular helper cells that are proximal to the FDC network can become infected, can make virus that's again reattached to the FDC network. So this becomes spatially and anatomically a separate reservoir. And now we're not talking about just RNA producing cells in the T cell zone. We're talking about the follicle. We're talking about this little engine of production that occurs in this unique anatomic space. And this is what it looks like. So what we've done is we've stained this tissue for PD1. And again, I don't get a lot of markers. I get one in this case. So PD1 that is localized over a B-cell follicle by definition is a T follicular helper cell. And so this green signal is another way of looking at HIV RNA. So in this follicle where you have lots of PD1 positive cells, most of the cells that are making virus are PD1 positive. In fact, in this case, it's all but one, are making HIV, are making virions. And so you can get the sense for what this engine of production in this one anatomic site looks like. And you can count those particles. And I could go through the methods with you if you're interested, but we have developed quantitative methods to be able to count the number of virions that are attached to the FDC network. And again, looking at these different lymph nodes at this different point in time, you can see that even in the earliest stages, in terms of per gram of tissue, it's 10 to the 8th virions are there and attached. That's true across all lymph node tissues and at each stage that we've looked at. So 10 to the 8th copies of RNA per gram translates into about 10 to the 10th total virions in the lymphoid tissue. This is an enormous reservoir of infection that we need to think about when we're talking about cure strategies. And the reason I say that is I can give you antiretroviral therapy, and what happens to this reservoir? Well, it turns out that it decreases. It's got a very rapid decay phase. But the question is it persistent? It doesn't matter if the virus is being made currently or not. Do these virions stay there over time, and are they infectious? And we can answer that question. The first thing that I want to tell you is that an experiment was done by Greg Burton in the mid-90s where he isolated B-cell follicles and dendritic cells, and he was able to culture virus off of those cells for as long as 9 months after the patient was aviremic. The only reason we say 9 months is because he stopped the experiment after 9 months. So at least after 9 months of therapy, there was still infectious virus on the FDC network. More recently, Mike Carroll and others have been looking at this, have looked at these cycling endosomes in the FDC network, and he showed that at least flu virus, when flu virus is attached, when the antigen is attached to the FDC network, it can be incorporated into these cycling endosomes, and then when it comes off of those endosomes, so it's within the cell body, when it comes out, it turns out that virus is infectious. He wanted to know if that was true in HIV as well. So he isolated follicular dendritic cells, he looked at these endosomes, and he said, is there infectious virus there? And this is what he found. So here are the patients that he looked at. These 3 were HIV negative. The rest of these patients were HIV infected. You can see that they were on therapy for 1, 10, 24, 8, 7, 6, and 13 years. And in every one of those patients, he was able to isolate and grow in culture HIV even from the endosome, from the cell body, even in patients who have been on therapy for 24 years. And in fact, some of the highest copies that he got were in patients who had been on therapy for 13, 14, 15 years. So this becomes a very important reservoir that we need to think about when we're thinking about the cure strategy. How do we get that, flush that virus out and eliminate it? And then the last point I want to make before I move on to the latent reservoir is that there's this question of persistence. And by that I mean, are there examples of patients who have ongoing virus replication in the tissues despite the fact that they're on antiretroviral therapy and their virus is completely suppressed, at least by commercial assays, so plasma viral load, in peripheral blood? And what we've done some work in this area, and the one piece of data that I want to show you, these are patients, we've been collecting tissues from patients who have been on therapy for at least 2 or 3 years, but have also been undetectable for at least 2 years. And we've gone through their tissues, and to do this experiment, you have to start at the top of the block, go all the way through the tissue, take every 5th or 6th section, and do your assay and look to say, are there RNA positive cells there? So here's an example of a patient who's been on therapy for 10 years. This is his lymph node, and you can see there are these rare but present cells that are expressing HIV RNA. Here's a patient who's been on therapy for 5 years. This is a rectal biopsy, and you can see there's this cluster of cells in his rectum that are producing fairly large numbers of HIV RNA. So in the 75 patients that I've examined so far by this technique, it's a fairly consistent finding that 40% of them will have these RNA-positive cells in their lymphoid tissue, and the frequency, it's very consistent. It's about 10 to the 4th cells per gram, and that turns into, for the total lymphoid tissues, that turns into about 10 to the 7th cells. Now, all I'm saying is that they're making RNA. I cannot tell you that these are infectious virions. That's a limitation of this technique. So I'm just going to leave it at that. But at least 40% of these patients have cells that are making HIV RNA. So to sum up the RNA reservoir, 98.4% of the viral RNA cells in lymphoid tissue. Early in the infection, the total number of RNA-positive cells is 10 to the 9th. The follicular dendritic cell network is an underappreciated reservoir. And in treated infection, 40% of patients have RNA cells that are easily detectable. All right, let's quickly move through the DNA story. So this is the in situ hybridization. When you go through and you count those cells and express it per gram of tissue, very consistent. It's about 10 to the 6th, 5 times 10 to the 6th cells. And it's in all of the tissues that we've looked at each of the time points. So the size of the population of DNA-positive cells is about 10 to the 6th, and that's about an order of magnitude greater than the RNA-positive cells, which is kind of what you'd expect. Now, all of these cells that are DNA positive, it doesn't mean that they're capable of making infectious virus. In fact, most of them can't. Most of these proviruses are defective. They can't make new virions. So the question is, how big is the inducible reservoir? I just want to make the point that when, and this is data that we've accumulated from a large cohort that we're following in Uganda, where we are able to go back every year and take a lymph node from these patients that are on therapy. And in these patients, there's about a 1 log decrease in the lymph node of DNA positive cells, and there's no change in the gut-associated tissue. So how big is the DNA reservoir in lymphoid tissue? If you follow this logic of 10 to the 6 cells per gram, you turn it into kilograms, you assume a 70 kilogram human, and you believe that 0.01% of the body weight is lymphoid tissue, and I can show you the paper that speaks to that. You get a population that's about 10 to the 9th cells, same thing in the gut. So the total DNA positive cells in the lymphoid tissue is about 10 to the 9th. That's a really big number if for those of you who don't believe that. It's a very big number. But how many of these cells can make new virus? Well, Bob Silicano and others have shown that the inducible reservoir is about 5 to 10%. So that's going to be somewhere between 1 times 10 to the 8th and 2 times 10 to the 8th cells in lymphoid tissue that are DNA positive can make new virus. That's a very big reservoir. And this is only in the lymphoid tissue that we've looked. We know from that other data that I showed you with RNA positive cells that you can find these cells elsewhere in the body. And we've not even looked in the brain or the lung, these other important areas. So the summary of the lymphoid tissue reservoir is an HIV infection. In blood, if your HIV RNA is about 30,000 copies per mil, and at least where I practice, that's sort of the normal when they come in for, with undiagnosed and chronic infection. That turns into about 10 to the 7th virions for 5 liters of blood. If you look at the latent reservoir, DNA positive, that's about 10 to the 9th cells. 10 to the 8th cells are inducible. If you want to look at the productive infection, RNA positive, we're talking about 10 to the 7th cells, and we can discuss the idea of persistence on antiretroviral therapy. And the FDC-associated virus, so we're looking at 4 different compartments here, 4 different reservoirs, is 10 to the 10th copies, and this can persist despite antiretroviral therapy. So where did the virus come from when they stopped antiretroviral therapies in that baby? We can talk about this, we can talk about this, and we can talk about this, but it's lymphoid tissue, almost certainly. So when we're contemplating a cure for HIV, William Shakespeare, I think, said it the best. The task he undertakes is numbering sands and drinking oceans dry. When you just consider the magnitude of the reservoir of DNA-positive inducible cells and where they're located. So that's kind of depressing. But we have to understand that's the magnitude of the problem before we just start throwing things at it without any idea of where do the drugs need to go, how do they need to work. That's really the challenge here, I think, as we contemplate a cure. So I just want to wind up and talk about one strategy that at least in my group we're working with. And if you think about the strategies to cure HIV, we can talk about antivirals. They don't seem to be getting us there. Latency reversal agents, gene therapy. We can try to enhance immune function with therapeutic vaccines, which I think David just talked about. Broadly neutralizing antibodies and immunologics. And here I'm talking about antibodies to various things that might activate the reservoir from latency or improve killing from NK or CD8s. So what we're doing is we're looking at the role of IL-15 as a curative agent. So IL-15 is a cytokine that's expressed mostly by monocytes that enhance NK cell function, at least in normal circumstances. And it's being looked at as a therapy for cancer, and several groups now are thinking about it as a therapy for eradicating the reservoir of inducible cells. So I'm going to be very careful. That's how I'm defining reservoir in this context. So there are 3 agents out there. There's the National Cancer Institute, which is just simply IL-15. There's the Admune, that's another formulation, which is the IL-15 that's linked to its receptor. This is now in the hands of Novartis. And then there's ALT-803, which is made by Altor. And what ALT-803 is, it's an IL-15 superagonist consisting of 3 components: the receptor, IL-15 that's permanently fused to the receptor, and they've added a mutation into the IL-15 into the sushi domain to make it more active, and then it's fused to the IG1 FC region. And so this is the molecule that we're studying in patients, and I'll give you, this is very preliminary data, and it's a fairly complex trial for regulatory reasons, as you can imagine, but this is what we're learning. So the reason we're looking at IL-15 for HIV, and this is just representative data. Many groups have shown this. This is data from Nicholas Chamont, but Brad Jones at GW has shown this as well, that IL-15 is very effective at inducing virus from latency when compared to IL-7. It's very effective and as effective as T-cell receptor antibodies. But this is in vitro with patient-derived cells. So it's in vitro. This is a patient with refractory leukemia who was given IL-15, so it's a cancer trial at our site. And we're looking at Ki67 positivity. These are NK cells, CD4 cells, CD8 cells. This is a single dose of IL-15. I believe this was about 6 micrograms per kilogram. That's a fairly good dose of a cytokine. This is before the dose. This is at day 3, day 5, and day 7. And the bottom line here is at day 5, you have peak biologic activity. And if you look at NK cells at 88.2% and CD8 cells at 30% compared to baseline, interestingly enough, you don't see what you would expect from the in vitro data. You don't see that degree of activation in the CD4 T cells. But this is what we'd expect to see and we hope to see. So and then the last thing is that we're using this subcutaneously, so we're giving it as a subcutaneous injection, not IV, and that is because of data showing that when you use copper labeled ALT-803 and you look in mice and you look after 630 and 60 hours at where the drug is accumulating, this is IV. The drug is cleared rapidly and does not accumulate in lymphoid tissues. This is sub-Q, and you can see that there's a prolonged half-life of the drug and that it's accumulating primarily in lymphoid tissues. And I just want to illustrate the point that I made earlier, that if you want to eradicate, you need to know where you need to go. And in this case, I would say it's the lymphoid tissues, and this drug accumulates in the lymphoid tissues. So this is the rationale for ALT-803 and HIV. It activates CD4 cells. It causes activation and proliferation of NKs and 8s, concentrates in the lymph node. It's got a long half-life when given sub-Q, and there's, at least in monkeys so far, there's been no antibodies generated against IL-15. Here's our protocol. It's a phase 1 dose escalation trial at 1, 3, and 6 micrograms. We started out much lower, but for a lot of reasons, we decided we'd rapidly escalate and start at 1, 3, and 6. So far, we've completed 7 patients. Well, we've dosed 7 patients. We haven't completed 7 patients for toxicity reasons, which is one of the issues. We started out at 0.3 in 2 patients, then rapidly moved to 1.0. We're still at 1.0 because of toxicity reasons, and this is one of them. So this is the injection site on day 5, and which you may not be able to appreciate, and you clinicians in the audience will get this immediately. This is a really big rash. It's an injection site rash, and by the Division of AIDS toxicity criteria for injection site toxicity, this is a grade 3 toxicity. So every patient who's HIV infected gets that, and 0 patients with cancer who get this subcutaneously gets that. So there's a big difference between the cancer patients and the HIV patients with respect to reaction to this drug. The other thing that you can't appreciate in this projection is the redness here. All of these patients get, and I really mean massive, inguinal adenopathy in the draining lymph node from the injection site. It clears after 5 days. These are great big tender lymph nodes that clear after 5 days. Changes in plasma viral load, because if we're reactivating virus from latency, we should be able to, maybe we should be able to detect it in peripheral blood. So what I'm showing you here is dose 1, dose 2, dose 3. This is 8, 16, and 24 hours after the dose. The negative means no RNA detective. detected. The positive means RNA detected, but less than 20, which is our lower limit. And then if we detected it over 20, we put the value in there. And the only point I'm trying to make here is that about half the time, we sort of got what we expected to see. They started out negative, and they turned positive. But less than 20 copies, so it wasn't a blazing, rip-roaring reactivation. There was no significant change in CD4 or CD8. But this is the really interesting part of the story so far. So this is a patient who got all 3 doses of 1 microgram per kilogram subcutaneously. Here we are in peripheral blood at baseline, 24 hours after the first dose, 24 hours after the second dose, 24 hours after the third dose. We were able to obtain a lymph node 5 days after the third dose. So this is the lymph node, and this is the blood paired with the lymph node. And so you can see that in terms of NK, CD4, and CD8, there's broad activation in that compartment after 24 hours after the dose of drug. There's some question about tolerance here. You had some reactivation at day 1, dose 1, a lot after dose 2, and then not so much after dose 3, and you sort of see that in the other CD4 and CD8, and we see this in the other patients as well. But the big story is in the lymph node, CD69 positive cells for NK, CD4, and CD8, massive activation with respect to CD69. Hard to, well, actually it projects pretty well. At least there are, in terms of absolute numbers, there's about a 3-fold increase of NK cells in the lymph node, in this lymph node, after ALT-803. We did not see, remember I told you 10 to the 4th cells per gram of HIV RNA? That's what we saw with this patient. So we didn't see, and at least in terms of this assay, we did not see a massive increase in RNA-positive cells, nor did we see any change in the DNA-positive cells. But the last thing I want to leave you with is probably the most provocative data from this small, limited study so far. John Carnes at Case Western has this EDITS assay, which is a nested PCR with sequencing of the envelope region to be able to determine the number of copies of envelope that are there. So it's a read of how much transcription has occurred or is occurring at that particular time. And what he does is he takes these cells, he will stimulate them with Con-A, and then he will do his assay to determine the number of reads of envelope. With every reaction, with every assay, he does a known number of sorted cells so that he can get a standard curve, and we can tell how many cells have been reactivated, at least by this assay, or at least are not reactivated, are transcribing envelope. And so here are our patients in a cumulative way. Here's day 0, day 7, day 14, and day 21. So this is without stimulation. The number of cells that are transcribing, it jumps at day 7. And this is, by the way, the trough measure. So this is blood just before we give the next dose of ALT-803. Day 14 and day 21. And again, we get that sense that there's an exhaustion happening here, that we're not getting as much transcription after multiple doses, at least at this short interval of dosing. And then with stimulation with Con-A, at baseline, you have this number of transcripts that are being made, day 7, day 14, and 21. But when you look individually by patients, you see a very interesting pattern as well. So this is the first patient that's not stimulated, day 0. This is cell equivalents per million cells. No transcription to speak of at day 7, really significant transcription, day 14 and day 21, and then the same pattern with the stimulation with Con-A. Now this was sort of the classic, this is what we'd really like to see, and I would like to stop the experiment here and publish this. Unfortunately, we can't. And this is the rest of the patients. So there's some issues here with some patients don't have a day 0, but you can see in every case we are getting transcription after day 0 with subsequent doses before we stimulate. And this is, John tells me, that in this assay with what he's done, this is the most transcription with any intervention he's seen in terms of what we're trying to accomplish here. So in summary, ALT-803 appears to have significant biologic activity in HIV patients that is distinct from cancer patients, significant activation and proliferation of T cells and NK cells, but interestingly enough, I'm not overwhelmed with the CD4 activation that's occurring here. But there is significant induction of HIV transcription. The toxicity profile is, and I have not spoken about this, but the FDA and I are good friends now. The toxicity profile of this drug is complex in the setting of HIV, and there's a lot of nervousness about using this kind of biologic intervention in this population of patients, because the FDA thinks of these patients as normal volunteers. So what they're willing, the Food and Drug Administration in the US, what they're willing to accept for risk is much less than if you're dying of cancer. And so that's another factor that we need to think about as we're contemplating all these really intensive interventions to cure HIV. So with that, I'll stop. I apologize for going a few minutes over. I just want to say that this is a very large group of people who have contributed most of the work. I want to particularly point out and thank Dr. Haas at the University of Minnesota, Kevin, our statistician, the surgeons who have literally followed me around the world harvesting lymph nodes, Jake Estes at NCI, Brandon at NCI, Danny, Michael at Case Western for helping me with the Uganda studies, John Karn for the EDITS assay, the really impressive people who do their work in Uganda, Brad at George Washington, who's joining the group to help us evaluate the reservoir using his techniques, and then the folks at Altor, especially Amy, who's helping us navigate these complex regulatory waters. And with that, I'll stop, and thank you very much.